everyone. I'm Aruni, and I work at St. Bartholomew's Hospital at Barts Health NHS Trust in London, Barts Cancer Centre and Barts Cancer Institute. Pretty excited for the second International Urology Cancer Summit, and I'm going to be talking about this game-changing novel prognostic MEET-URO score in metastatic renal cell carcinoma on first-line immunocombination therapy. As you can see, these are all my affiliations and organizations that I'm linked with. And here are my disclosures. I'm the co-founder and chief medical officer of OncoFlow. Right, so let's get on to the first slide. As an introduction, this score that we created is on first-line immunocombination therapies. But let's have a look at the first-line treatment landscape in the metastatic renal cell cancer setting. And it all started with the 1990s, the era which we call the cytokine era. And then we went on to the 2000s and 2010s into the targeted therapy, where we've got Sunitinib, Sorafenib, all the VEGF inhibitors. And then as we progressed, we went on to the IO therapies in Axi, Nivo, Cabo. And then finally, in around the 2019 to 2021s, there was a revolution in the immunocombination therapies, chiefly IO-IO, which is EP-Nivo, and the other four combinations, which is Pemlen, Avi-Axi, Nivo-Cabo, Cabo-Nivo, and Pem-Axi. Those were the IO-VEGF inhibitors or IO-targeted TKIs. So once we have an understanding of this landscape in the metastatic renal cell cancer setting, I'm going to take you through a brief revision of the IMDC score, which has stood its ground for the last 20 years. And as you can see, the predictive variables or the predictive factors, which I tend to call them, as you can see, the time from initial diagnosis to treatment and the Karnofsky performance score, hemoglobin, calcium, platelets, neutrophils, these were the ones which were the basis of the IMDC criteria. And as you can see in your MD Calc or any other calculator, you can or Oncoassist, you can calculate the IMDC score and then group it into favorable, intermediate, and poor prognostic risk categories. And as you can see, Pals et al. Had the ESMO renal cell cancer guidance in 2024, where treatment selection based on favorable or intermediate and poor risk, as shown in this slide. And as you can see, the median overall survivals of therapies, that's from the 2019 ESMO guidance document. And once we've had this framework and revision of the IMDC score and risk categories, let me take you on to the MEET-URO score, which adds two variables to it. One is the neutrophil lymphocyte ratio, and the other is bone mets. So when the Italian group, the MEET-URO group, were developing this, they assigned 1 point to bone metastases. And if you had a neutrophil lymphocyte ratio of more than 3.2, then it would have 2, 3, and 6 for the intermediate and poor prognostic IMDC score categories. And if you can have a look in this table that's from the Rebuzzi et al. Paper in 2021, you can see the 5 prognostic groups that the MEET-URO has, as opposed to the 3 prognostic group IMDC. And if you have a look carefully, it really prognosticates the intermediate and poor risk categories of the IMDC better into groups 2, 3, into groups 3, 4, and 5. So the prognostic factors are well demonstrated in this graph over here. And as we go on to the C indices, basis of comparison, the Harrell C index is what we use as a statistical tool to compare between IMDC and MEET-URO when the Italian group first built this tool in the second line and onward Nivolumab setting. You could see that the C index for MEET-URO was 0.69 as opposed to 0.64 for the IMDC. Once this was created, we went on to an internal validation study, which was done in 86 Italian centers as part of the expanded access program in Italy. We had 306 patients enrolled for the study. It was a retrospective one, and it only focused on the first-line EP-Nivo setting or the IO-IO group. And as you can see, we've got exciting diagram from the Ribuzzi et al. Published paper in 2022 in ESMO Open. You've got overall survival, where again the C index was better, 0.73 versus 0.65 of IMDC. Coming to the progression-free survival, again this model performed better, 0.67 versus IMDC 0.59. And you can see that the MEET-URO performed better in the overall response rate, ORRs, as compared to the IMDC in this graph. One thing to note here that we only operated on groups 2, 3, 4, 5 of MEET-URO and intermediate and poor. We didn't have group 1 or the favorable group of the IMDC because these results were based on retrospectively the Checkmate 214 where the favorable risk didn't have the first-line EP-Nivo. And that's why we didn't have any group 1. But we did have the other 2, 3, 4, 5 prognostic parameters as compared to the intermediate and poor IMDC groups. So getting this into background, we wanted to externally validate this. So this was presented by Sarah in IUCS 2023. We wanted to validate it externally using more centers, more patients, more multinational collaboration. I was given the opportunity to lead this by Sarah and Giuseppe Banna and the entire MEET-URO group. And I recruited a lot of British centers all around the 4 UK nations. We had around 24 UK centers, around 2 other European centers, and 2 Asian centers in Turkey and Hong Kong. And we recruited a total of 1174 patients. It was retrospective. If you can see the internal validation, which I showed you, was on only the first-line EP-Nivo setting, but here we had patients with 2 IO TKI settings as well, which is Avi-Axi and Pem-Len. So around 50% of the patients were EP-Nivo, around 20 to 30 patients were Avi-Axi, and around 14% of those patients were had Pem-Len. And as you can see in the external validation, if you compare IMDC versus MEET-URO, we've got a C index of 0.68 in the MEET-URO arm and 0.65 in the IMDC, which again proves that it better prognosticates all the IMDC as opposed to only. So if you have a look at this study, so we've got all the 3 all the 3 prognostic groups of IMDC and all the 5 groups of MEET-URO, as opposed to only the intermediate and poor in the Italian internal validation study, which is why this external validation was groundbreaking and so important. And there is a comparison of the prognostic groups in terms of overall survival, which these diagrams are made of. So 46 months, 38 months, and 16 months in the favorable intermediate and prognostic groups of IMDC, and a range of 46 to 10 months in the MEET-URO 1 to 5 prognostic groups. Having said that, a paper is being planned on this at a later date. The question is, what is the future, or what is the scope or implementation? And I'll take you to my next slide. Well, the MEET-URO score in practice and can be implemented in the first-line EP-Nivo setting, in the second and onward line Nivolumab setting, and the second and onward line Cabozantinib. And I can show you a link over here, and if you go onto that link, you can use it for your calculator. Prospectively, a prospective trial is what we need at the moment, and that's the Renal study. So we're planning an international multi-center real-world registry for prospectively validating this score. At present, the MEET-URO score has already been cited in the European Association of Urology guidelines. So as we go on, we would be wanting to externally validate this in the second-line Nivolumab setting and the second-line and onward Cabozantinib setting, both of the studies which are underway as we speak, and hopefully we'll be able to present them at further ASCO, ESMO, and further IUCS conferences over the years to come. What I see the MEET-URO as a game-changing score. We've got a revolution in the immunotherapy landscape in the first-line metastatic renal cell cancer setting, and that's why we needed a score to validate from the immunotherapy perspective in metastatic renal cell cancer, and I think it's a game-changing score. It adds better prognosis and better treatment selection and better predictive treatment in terms of treatment choices and survival groups. Looking forward to a very successful IUCS. Thank you.